Good afternoon. My name's Rachel Norton. I'm a geriatrician at Ipswich Hospital, and today I'll be presenting on our local experience of implementing the Eat, Walk, Engage program on our orthopaedic ward. So Ipswich is a 400-bed secondary hospital. We have a single orthopaedic ward, and we run a orthogeries fracture liaison service where we see about 125 hip fractures a year, plus an assortment of other consults. For context, here's a quick look at our registry data. Approximately half of our patients are malnourished, either at admission or subsequently during the admission. So we're this large blue bar in the middle there. 92% of our patients have the opportunity to mobilise on day one, but unfortunately only 26% manage it. So we're down the bottom of the graph there with the blue arrow. We have quite a high rate of delirium. 40% of our patients either are delirious at admission or become so during their admission. And for all of those reasons, we're a ward that really benefits from programs like Eat, Walk, Engage. So Eat, Walk, Engage is a ward-based multi-component intervention which is tailored to the local context, and it's evidence-based. So some of you may have come across the JAMA article this year, which published the results of the CHERISH trial, which demonstrated that compared to control wards, Eat, Walk, Engage wards had a reduced rate of hospital-associated delirium. So what is Eat, Walk, Engage? Look, essentially, the Eat, Walk, Engage program supports the existing staff, existing multidisciplinary team on the ward to implement local solutions to improve nutrition, mobility, and cognitive and social engagement for the patients, with the aim of reducing hospital-associated complications. Structurally, there's a Eat, Walk, Engage facilitator who's centrally trained, and there's a part-time multi-professional assistant who might be from an allied health assistant or a nursing assistant background. But the real magic of Eat, Walk, Engage is actually in the iterative cycles of improvement, which are driven by local data and local priorities. So at the beginning of Eat, Walk, Engage, you do some audits to see where you're starting from. And we found on our ward that at the beginning of the program, 17% of our patients were lying flat in bed when their meal arrived, and only 20% were sitting in a chair. Also, 1 in 5 of our patients were eating less than half of their meal, which was just compounding that baseline nutritional deficiencies. So in the monthly working group meetings, we set about laying out the challenges to nutrition on our ward, and chief amongst them was that we all recognised that our ward is quite nursing heavy when it came to nutritional assistance. 80% of our patients needed either set-up or full feeding assistance with meals. That obviously took up a lot of nursing times. There were other issues as well, though. We use fairly old-fashioned paper menus, which are impossible to fill out if you're visually or cognitively impaired, and even if you do fill it out correctly, you may not get the meal you ordered. We have bamboo cutlery that's rough in the mouth and doesn't encourage eating. And there were consistent and multiple different difficulties with ordering and supply of materials. So things like high-protein supplements, even water jugs, were difficult to come by when they were needed. And there'd been recurrent problems with patients who'd been fasted for theatre and then cancelled, not being able to access a meal because the system didn't allow one to be ordered. And after-hours meals were also a consistent challenge. So one of the early focuses for our ward was mealtime positioning. Through a process of staff education and posters and staff champions, we managed to achieve a bit of a cultural change where we stopped focusing on the tasks for the patient and started focusing on the patient themselves. And it became a matter of, it's more important that they're out of bed before their meal than whether the medication round is 10 minutes late. Our nurses became more skilled in mobility assessments and more confident in getting patients out of bed. And this was assisted by the multi-professional assistant. We also conducted a chair audit and discovered we needed 15 more chairs so that there could be one in every bed space. And as doctors, we started actively giving permission and setting the expectation with our patients that sitting out of bed for meals was part of their recovery. Sometimes, COVID permitting, we even had shared meal times in our 4-bed bays, which was really lovely for the patients and staff and improved everybody's willingness to be out of bed. And at a year into the program, we'd noticed some really significant results. So now 3% of our patients are lying flat in bed when their meal arrives, and 1 in 4 is sitting in a chair after those interventions. Interestingly, simply improving position had a lot of flow-on effects. So you'll recall all of these challenges. But once we had people sitting in a more ergonomic position for their meal, fewer of them required assistance to either set up or consume their meal, which frees up nursing time to do other tasks. So suddenly our nurses had a little bit more time to do the menu with the visually or cognitively impaired patient and try to get them a meal they might actually eat, source some adaptive cutlery, and in other ways support improved nutrition. And on the logistics side of things, our dietitian particularly, and a number of the senior nurses had conversations with kitchens and supplies about ensuring that we have adequate stock of high protein supplements, adequate stock of equipment, and also an improved system for ordering after hours meals and meals for cancelled theatre patients. We went through a similar process and continue to go through a similar process on engagement. So in our meeting, it was clear we have multiple challenges to engage on in our ward. There's a high rate of prevalent delirium, yes, but there's also nowhere to go, nothing to do, and nobody to talk to, which I think is fairly standard across hospital wards. Most of our patients can't afford to hire their TV, which is the only engagement on offer. And so the baseline audit showed that they spend 63% of their time alone. In terms of solutions, again, it was multifactorial. One of the local favourites has been the Sunflower Biography tool, which we'd actually started using prior to Eat, Walk, Engage, but the program gave it this push along to make it part of everything we do. So at every bedside, there's a wipe clean poster which has key personal facts about a person. What's their dog name? How do they like to have their cup of tea? And that can be updated by themselves or a staff member or family. It's something that our nurse specialists use a lot to engage with patients, but we've also actually found that our non-clinical staff, our wardsmen, use it to have a chat with the patient on the way to their x-ray. And it's useful in both the management and prevention of delirium in our experience. We developed a number of destination spaces. So here's the library with our lovely multi-professional assistants. It's down the end of the hallway, so you have to walk there if you can. And we have a pet wall, a Scrabble wall. But the team really outdid themselves actually with the activities and resources. So we are now an orthopaedic ward that is resourced like a geriatric unit. We have boxes of things to do. We have music, there's engagement boards, there's more awareness of the access to free Wi-Fi. It's Queensland, so there's a poster and event for every sporting event that is held. Our therapy dog has a birthday, and we do some group activities whenever COVID allows. With those interventions, the amount of time that our patients spent alone dropped to 45%. And you'll notice in this graph, that's not because there were more visitors. It's the same staff we already had engaging more with the patients because it's become a priority and because we've changed the workflows that they're using their time on. Now, I'd love to talk you through the walk component. Unfortunately, time does not allow, but suffice to say, walking is challenging on an orthopaedic ward, and we're continuing to work through some strategies for that, and we're expecting to see some improvements in the next audit. So what insights have we got from our local experience of Eat, Walk, Engage? I think it's very clear that we have found the repeated small cycles of change work. And the beauty of this program is that it's not imposed from on high. It empowers our local staff to address the issues that they've been wanting to address for probably years by coordinating those efforts together. And because it's the local staff's idea and our local solutions, we've built this positive culture where people feel like they can make a difference to patient care. And so there's been flow-on effects to other improvements in patient care that are well beyond the Eat, Walk, Engage program itself. We've definitely found that other wards in the hospital notice and are interested in the program, and families and non-clinical staff notice the difference as well. Importantly, COVID hasn't stopped us. We've flipped into a COVID ward twice this year, but we've managed to keep the process going in the background through the monthly meetings. So that's not a reason to not do it. So if you're interested in learning more about eWalk Engage, here's some of the contact details for the central program. I'd particularly like to thank Professor Alison Mudge for her support in developing this talk, and also our 5F orthopaedic ward clinical team for all of the amazing work they've done. Thank you very much.